My name is Dr. Delphine Rea. I'm a physician, a hematologist based at the Hospital Saint-Louis in Paris, France. Well, the availability of tyrosine kinase inhibitors from 25 years ago have provided fantastic progress for patients with chronic myeloid leukemia. Before tyrosine kinase inhibitors were made available, the 5-year relative survival rate was low. It was about 54%. Most of the patients were dying from the disease, mostly from acute transformation. Now, since tyrosine kinase inhibitors are in the therapeutic arsenal to treat our patients, the 5-year survival rate have fantastically increased, and from 2001 to 2008, it is now considered as reaching 80%, which is really high. So most of the patients right now will not die anymore from CML. Thanks to the tyrosine kinase inhibitor, starting from imatinib, available from 2001, which was mainly used first line and which is an ATP competitive inhibitor, the first generation. Then the second generation tyrosine kinase inhibitor, dasatinib first, nilotinib, and then bosutinib, which were first labeled to salvage patients who failed imatinib, which right now are also used in the frontline setting. And then the third generation ATP competitive TKI, ponatinib, which is one of the strongest ATP competitive TKI, also active against the so-called gatekeeper mutation of BCR-ABL, the very famous T315I. And ponatinib is here to salvage patients in the second-line setting or beyond. So all these drugs bind to ATP binding site of ABL1, with differences in potency and off-target effect profile. Now, since recently, we have a very new class of drug available for our patients, the allosteric tyrosine kinase inhibitor, which are very selective, and asciminib is at the forefront of this new class, and it is currently labeled mainly in the third-line setting or beyond. It is called a STAMP inhibitor. It has been already approved frontline in some part of the world, such as in the United States, and in other parts of the world, the approval process is pending. What's very important to figure out for our patients treated for chronic myeloid leukemia is that very few of them will reach a state that we call treatment-free remission. Most of them will have to continue their treatment lifelong. So we need to care about not only efficacy, but also safety and quality of life. And a lot of tyrosine kinase inhibitors are going to generate low-grade related side effects. These side effects are not going to be dangerous. They are not going to jeopardize the prognostic, but they are likely to impair in a daily fashion the quality of life. And the most frequent low-grade side effects are the fatigue, the pain, either headache, myalgia, muscle cramps, arthralgia, or bone pain. The third point is the skin, the rash, or the peripheral edema, and some of the TKIs are also going to generate gastrointestinal discomfort, such as diarrhea, nausea, or vomiting. And clearly, these low-grade side effects are going to be a source of potential decrease in compliance. And it is one of the major causes of treatment failure if we don't care about this, if we don't provide supportive care and or eventually decrease the dose of the treatment. But decreasing the dose of the treatment may lead to a CML relapse. So we need to be very careful about those. What we have to know about tyrosine kinase inhibitor is that most of the ATP competitive inhibitor available today are not very selective. So they do not only cause potentially low-grade side effects, but also sometimes more serious TKI-related side effects. And this serious side effect profile depends from a drug to another. With imatinib, the very serious side effects are quite rare, But we must be aware of the fact that some patients may have hepatitis during the first year of the treatment mainly, requiring very often treatment discontinuation as a switch to another treatment. With nilotinib, it's mainly the hepatic enzymes or the pancreatitis which can occur. Mainly, it's biological elevation in lipase, usually very benign, but sometimes it leads to real clinical pancreatitis, which usually requires treatment interruption and eventually discontinuation. Now, with dasatinib, the lung is the main target. Very frequent pleural effusion, which depend on the dose, on the age of the patient, but we do not depend on the duration of exposure. You may have pleural effusion at the beginning of the treatment or many years after. Very rarely, the pulmonary hypertension, which is potentially life-threatening. So if this happens, the treatment is to be discontinued forever and a switch is necessary. With bosutinib, there is a cross-intolerance potentially between bosutinib and dasatinib about the lung, the pleural effusion, the pulmonary hypertension. But what patients complain most about, besides the low-grade side effect, is the hepatitis, which is very frequent during the first year of the treatment and is not very sensitive to dose reduction and usually requires treatment discontinuation. With ponatinib, we have to be careful about the ischemic events and the hypertension, and this is also a risk with nilotinib. And by the way, nilotinib may sometimes trigger hyperglycemia and also hypercholesterolemia, but it's both LDL and HDL cholesterol. But these are risk factors for ischemic events. Finally, with asciminib, which is a STAMP inhibitor, which is much more selective, of course, the side effect profile is reduced, but is not completely abolished. So we may be aware of the fact that sometimes some patients may have to face pancreatitis, and this needs to be taken into account with eventually dose interruption and restarting at a lower dose. Of course, while we're discussing here about the side effect profile of the tyrosine kinase inhibitor, either low grade and high grade, we must not forget that efficacy is something extremely important for the prognostic of the disease. And the effectiveness of tyrosine kinase inhibitors is mainly evaluated by cytogenetic and molecular responses. And it is important to remind that a complete cytogenetic response and its molecular equivalent is about 1% of BCR-ABL transcripts or less, is the gold standard for an optimal outcome in CML. But by optimal outcome, I mean progression-free survival and overall survival. I don't mean treatment-free remission, which is very different. The second generation ATP competitive TKIs induce responses faster than the first generation drug imatinib, but it is not clear whether they provide a survival advantage in the first-line setting, since we have to remember that in clinical trials there is some kind of crossover effect, because when a survival is collected, some patients may have left the trial and be treated, fortunately for them, with another treatment. Now, there is some evidence that at 96 weeks for asciminib in the first-line setting, though we ask for first, a very important study, which compares asciminib to ATP competitive TKI in the first-line setting, or even in the second-line setting or beyond, like in ASSEMBLE, suggests that it offers a better benefit-risk profile than either of the first-generation tyrosine kinase inhibitor imatinib or the second-generation ATP competitive TKI, dasatinib, nilotinib, or bosutinib. When we take care of a patient, usually us as physicians, we collect, of course, the adverse event, but we rarely raise the point of the quality of life and the impact that either the disease or the side effects may have on the daily life of the patient. So usually there is a discrepancy between what patient feels and what we perceive. So clinicians usually largely ignore the impact on the patient of the low-grade treatment-related symptoms. And in fact, patients differ in how they consider their quality of life. Each patient is a different individual, and their quality of life may really be impacted by TKI-related side effects. And in the Sun survey of unmet needs, so-called the CML Sun study, we have demonstrated that patients fall into three main groups. The patients with severe side effects, and they really need to have a change of treatment. Now, there are some patients with mild side effects that are well managed, either with supportive care or with dose reduction or with supportive care plus dose reduction. And the third category of patients is those for whom no TKI change is indicated, but their quality of life is severely impacted. So I think we have to introduce new tools in the routine practice, and these are the patient-reported outcomes. And these questionnaires can support clinicians in better understanding the daily impact of TKI on individual patients. The second step will be to better translate these into an efficient prescription and into an improvement of the quality of life of our patients.
My name is Andreas Hochhaus. I'm head of the Department of Hematology and Medical Oncology at Jena University Hospital in Germany, and I'm coordinating the German CML study group. After the introduction of tyrosine kinase inhibitors into the treatment of CML 25 years ago, a lot of things have been observed. First, the survival is now very, very good, but most of our patients still suffer from side effects, from early side effects during the treatment, but also long-term side effects which should be avoided. And of course, if we ask our patients who have a long-standing treatment of CML what their wish is, the most of them answer the improvement of quality of life. That means they want to avoid the daily problems. Therefore, new inhibitors have been developed, the second generation inhibitors, to improve response mainly. And we have observed during the development of the second generation inhibitors that treatment-free remission might be an option for a proportion of our CML patients. That means in deep molecular response, we are able to discontinue the therapy. And of course, being off treatment is the best way to achieve a good tolerability, a good quality of life. But even with these second generation inhibitors, side effects remained, and therefore a more specific treatment which is targeting BCR-ABL only, but not alternative off-target kinases in the leukemic cell, was important. And therefore, the development of asciminib as a so-called STAMP inhibitor, selectively targeting the myristoyl pocket of BCR-ABL, being very specific to BCR-ABL, was so important. The pivotal ASSEMBLE trial was developed, a trial which was a randomized trial comparing the standard of care for third-line treatment and later lines, which was bosutinib compared to asciminib. And during this trial, we have seen a major advantage of asciminib for efficacy, early molecular response, and also good tolerability. In comparison with bosutinib, the gastrointestinal problems which have been observed on bosutinib were not observed with asciminib. We have seen some early cytopenias with both drugs. And based on this third-line data, of course, we went into the first-line application of asciminib, which is now most important because we were asked by our patients to develop a drug which has optimal tolerability with good efficacy. And this is the final result of the Ask for First and also Ask for Start studies, two studies which had the aim to demonstrate an advantage in efficacy of asciminib over standard of care, which was in ask for first either imatinib or a second generation tyrosine kinase inhibitor. And in ask for start, we had the endpoint of tolerability. That means to demonstrate that less patients discontinued treatment due to adverse events with asciminib over the standard of care in this study, which was nilotinib. And this has been shown in the Ask for Start study, even in an early interim analysis. We wanted to see 64 events, and the interim analysis was done after 50 events, and we have demonstrated that more patients, actually double number of patients, discontinued nilotinib based on adverse events compared to asciminib. That means the tolerability of asciminib as a BCR-ABL-specific drug is much better in the first-line use than with all the standard of cares which have been investigated, imatinib and second generation in Ask for First, and nilotinib specifically in Ask for Start. Of course, of major interest are the PRO data, that means patient-reported outcomes, which have been analyzed for Ask for First already, but only in a subgroup of patients, but demonstrated an advantage of asciminib. And I'm looking forward to the final analysis of these patient-reported outcome data. In patients who do not respond very rapidly to asciminib, either in third line or in the first line situation, we have observed some mutations. And these mutations are mainly in the myristoyl binding site of BCR-ABL. And of course, to avoid such mutations, for a subgroup of patients, we are looking for combination options. And for that aim, we did a pilot trial in Germany, the Fascination trial, which combined ATP competitors in the standard of care dose with different doses of asciminib. And we have observed a very good response rate with these combinations, but of course also side effects which are mainly based on these ATP competitors. However, patients who had mutations outside of BCR-ABL, we talk about ASXL1 mutations, for instance, had no disadvantage with these mutations compared to Ask for First, and also the study from our Australian colleagues who showed that patients with ASXL1 mutations may have a disadvantage on asciminib monotherapy. Therefore, I think it's now time to go into these combinations to test whether these combinations can overcome the disadvantage of ASXL1 mutations in parallel to the BCR-ABL in CML. Apart from these 6 drugs which are now registered for the treatment of CML, we see new developments. We see an improvement into the ATP competing drugs like the Enliven 001 drug in this the ENABLE study, which is a phase 1 study in monotherapy with this drug. Olverembatinib, which is actually very similar to ponatinib, has been used mainly in China for third-line use, but is now going into earlier stages of CML as well. And TERN-701 in the Cardinal study is also a phase 1 study. TERN-701 is a myristoyl site inhibitor like asciminib, but may have some advantages as well because it has a different pharmacodynamic and pharmacokinetic profile. Using ATP competing drugs, the quality of life is mainly based on the off-target activity of the second generation and third generation drugs. Therefore, it was important to test lower doses of these drugs in treatment of CML, whether a patient on a lower dose may have a reduced incidence of side effects. And the first one was ponatinib. Standard dose was 45 milligrams, and for late line use in case of T315I mutations or after second generation tyrosine kinase inhibitors. But with 45 milligrams in studies, 20% of patients had severe cardiovascular side effects. The company developing ponatinib did a randomized phase 2 study, tested the dose reduction of ponatinib to 15 or 30 milligrams. And the result of this OPTIC trial was that 45 milligrams are really the recommended dose at the start of therapy, but after response, less than 1% BCR-ABL, a dose reduction to 15 milligrams is now recommended. And with this dose reduction, the number of cardiovascular events was significantly reduced. Dasatinib is a very interesting ATP competing drug because of its short half-life. It's a multi-kinase inhibitor inhibiting many other kinases apart from BCR-ABL. And the main side effects of dasatinib are pleural effusions and pericardial effusions in more than 20% in studies on 100 milligram every day. And there are two approaches to avoid this. One approach is to reduce the dose in all patients, and our colleagues in Houston at the MD Anderson Cancer Center did such a trial, a non-randomized trial with 50 milligrams dasatinib. They have observed a very good efficacy and a reduced incidence of side effects. We had a different approach in Germany. We approached 5 days per week with 2 days treatment holidays in a randomized fashion versus 7 day per week, 100 milligram. And the endpoint was, of course, lack of inferiority. That means same MMR rate in our patients and reduction of side effects. And we have observed with this approach in first-line patients halving of the incidence of pleural effusions, but the same efficacy, the same MMR rate. This applies to first-line use only, not to second and later line of therapy. Therefore, our recommendation now, at least in the German recommendations, is to use 80 to 100 milligrams of dasatinib first-line 5 days per week, and in later lines 7 days per week. Other colleagues, studies which are still running, like the HALF study in the Czech Republic, which reduces the dose prior to treatment discontinuation to avoid the so-called withdrawal symptoms after discontinuation of the drug. And this is a two-step approach. In the first step, all drugs are just given in 50% dose. And on the second step, if this was successful, another 50%. That means they use a quarter of the initial dose only. I have some reservations on that. I have concerns. My concerns is that all the drugs have different pharmacokinetic profiles. That means we should do it specifically for all the drugs. I think that with dasatinib, that's approachable because dasatinib has a very big therapeutic window in contrast to imatinib and nilotinib. And therefore, I think we should find specific approaches for each specific drugs. For asciminib, the initial dose in studies was 40 milligrams twice daily. We have demonstrated in Ask for First and Ask for Start that 80 milligrams once daily has a very good efficacy and is of course advantageous for the quality of life, because the drug should be taken on an empty stomach, and this is of course easier in a once daily schedule. This was systematically tested also in other cohorts in the Ask for Opt study, which compared 40 milligram twice daily with 80 milligram once daily. Therefore, my conclusion is that 80 milligram once daily of asciminib is now standard of care for all the lines of therapy. except the threonine 315 isoleucine mutation. Here, a higher dose has been registered in many countries, not in the European Union for the time being, but we expect an acceptance of the higher doses as well here. Of course, TFR is the ultimate goal of our CML patients who want to achieve an optimal quality of life. The eligibility for TFR has been demonstrated in about 40% of our patients who achieve a deep molecular response after 3 to 5 years of therapy. This was systematically investigated in a large European trial, in the EuroSki trial, and we have observed that from these 40% who are eligible for discontinuation, 50% remain stable. What we want to achieve in the future is, of course, to increase the number of patients who are eligible for TFR. That means to increase these 40% by increasing the proportion of patients in deep molecular response, and also achieve a more stable situation after discontinuation. That means we want to improve the 50% who remain stable after discontinuation of the drug. And of course, a drug which has faster efficacy, like asciminib, may have the chance to improve both points. That means first to improve the eligibility criteria, but also to maintain the major molecular response in patients after discontinuation. This is ongoing. This has been implemented into the Ask for First and Ask for Start studies, and I'm looking forward for the data.
Hello, my name is Ehab Atallah. I'm one of the leukemia doctors here at the Medical College of Wisconsin, Division of Hematology and Oncology in the US. I'm also the medical director of the H. Jean Coury Cure CML Consortium, which is a CML consortium in the United States to improve the care of patients with CML. The survival for patients with CML has been really good and has markedly improved with current therapies that we have, the tyrosine kinase inhibitors. And the question now is, how can we improve their quality of life for the many patients that need to stay on this lifelong therapy? There's kind of perspectives from physician and patient perspectives on the quality of life for CML. So from the patient's perspective, their first concern, of course, is stop and disease progression. They want to make sure that they stay in remission and their disease stays under control. There's also a huge unmet need in terms of improving their quality of life and improving their side effects. When should they switch their treatment? Patients have repeatedly talked about they want to be part of their decision making. What can they do to improve their quality of life? From a clinician perspective, we've always focused on deep response. How can I manage my patient without any serious side effects and keep them in a deep response, prevent progression to accelerated phase or blast crisis, and also maintain their long-term survival? There's studies from Europe that have showed that survival for patients with CML are similar to the general population. It's not really similar in the US, where we do find that patients with CML still have inferior survival compared to the general population. So having that communication and between the physician and the patient, and what are they each expecting and hoping for is really really important. The most important point is to identify that our patient is having issues with their treatment, with their TKI. So understanding how much are these symptoms really bothering the patient. So for example, if someone has 1 or 2 times diarrhea a day and they have an office job, that might be acceptable to them. However, if someone is a truck driver and has 1 or 2 times diarrhea a day, that's not acceptable because they don't have easy access to a restroom right away. The symptoms and how much they bother our patient are relative to the patient and their quality of life and what they do. As physicians, we very frequently focus on the severe side effects, and unfortunately, very frequently forget about the more mild side effects that are affecting our patients, the quality of life long term. So identifying those, discussing them with the patient, understanding how much they're affecting their life, and asking them, should we do something about it? Like, it's a very common question I ask my patients, like, is this bothering you enough that you want us to do something about it? And some patients will say, no, I'm fine, I'm used to it. Or some patients will say, no, I really can't. Fatigue is another very common one. How much is the fatigue? Again, if you have a more sedentary lifestyle, some mild fatigue doesn't bother you, but if you have a much more active lifestyle, that could be bothering you more. So identifying how these side effects are affecting the patient is really important. From there are several strategies we could consider. The first one is simply supportive care. Supportive care is patient has diarrhea, we give them an anti-diarrheal. Have some nausea, we give them medications to prevent that. Fluid retention, maybe diuretics. Fatigue is a very difficult one to manage. Exercise maybe is included, acupuncture. But the first thing I try is to do supportive measures. Also, very frequently, these symptoms do improve with time. So in the first 2 to 3 months, I do my best, if it's not a severe side effect, to not make any changes, because some of these side effects do improve. The second way to improve our patient's quality of life is by reducing the dose. And that's something I consider in patients who are in a really good response. So they're already having a really good response. I could consider reducing the dose. We do have multiple studies that have shown that a reduced dose of TKI in responding patients is a good choice. That usually does improve the patient's quality of life and does reduce the side effects. We also do have some studies with some of the tyrosine kinase inhibitors that starting at a lower dose could be something you could consider. So that's the second approach you could consider. More recently, there was a study called the Rodeo study, where there was a shared decision making between the patient and the physician of having a discussion and understanding the implications of a reduced dose. Does the patient want to reduce the dose or not? And how will they be monitored after that? The third strategy, if that doesn't work, is to consider switching therapy. And there's a kind of a balance there in switching therapy, either too fast or too slow. Too fast is like you just jump from one TKI to another. As soon as someone has a side effect, you jump to the next one. And then there's also too slow, where someone comes in and says, I'm tired, and physician says, well, there's nothing I can do. You'll just stay tired. And they maintain that, not understanding that they do have other options of switching to another TKI that maybe might improve their fatigue. We don't know that, but if someone's quality of life is significantly affected, then maybe a switch would be a good idea. And there's really a balance between the too fast and the too slow, and it's a discussion with the patient for sure. Finally, the best way to improve our patients' quality of life is actually discontinuation. And in a select group of patients who are in a sustained deep molecular remission and have been on a TKI for at least 3 years and are willing to be monitored closely after they discontinue their drug, this is a group of patients that we could discontinue their drug, monitor them closely. Of the patients who are eligible to discontinue, half of them will be successful in permanent discontinuation, and half of them will need to go back on drug again. We've shown in our studies that in patients who discontinue their drug, that their quality of life did improve, specifically nausea, fatigue, diarrhea. All of these improved with TKI discontinuation. Again, this is in a select group of patients, and it's a discussion that needs to be had with the patient. There was a very interesting study, which was called the CML SUN study. And in that study, very frequently, physicians did not discuss with their patients enough their quality of life and how they're doing, and how is this affecting their life. So I think as physicians, we need to discuss this more with our patients and bring it up and understand that there are other options. We also can include other specialists. So there's depression psychologists, involve our social worker to help them. There are some other symptoms that we could help with, and kind of build a team around the patient and tell the patient it's okay to have these symptoms. It's okay to discuss them. We do have tools to use, which include the promise measures or the quality of life measures. These are very good, very enlightening. They've been shown in other cancers that they are very good in even prolonging survival in patients with solid tumors. In CML, we have not used them enough. I can tell you from our studies using patient-reported outcomes, we learn a lot from them, and we can adjust, educate our patients about the options they have if we do use patient-reported outcome measures. Can we also use some of these measures being integrated into our EHR, our electronic health records? Absolutely. That is something that is ongoing, and I hope that it spreads more. In summary, we really need to remember to talk with our patients, shared decision making. We can and we should try to improve the quality of life for our patients with CML. So thank you.